Good evening and namaskar. I am Dr. Rajashree Ray from India, and on behalf of the American Academy of Yoga and Meditation, I welcome all of you and bring you greetings for the season. AAYM is a not-for-profit organization of physicians, researchers, medical professionals, and practitioners of yoga and meditation. This organization is dedicated to education, learning, and research on the use to enable us to have a better place to live on this planet. It, of course, fosters an interdisciplinary approach linking science, arts, ethics, community, and spirituality to enable humans to achieve their highest goals. Today's webinar topic is addressing comorbidity in mental health. Before we move on to this topic, I would like us to remind ourselves that WHO, way back in 1948, defined health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Since this definition was officially published in 1948, we have meant health and seen health as a picture that not only has physical factors, but alongside mental, emotional, social, and even spiritual factors. Over the years, multiple long-term conditions are becoming now the norm rather than the exception, and the number of people with comorbidities is set to increase in the coming years. Health risk behaviors and physical illness increases the risk of these comorbid mental disorders, while mental disorder results in higher rates of comorbidity. Therefore, tonight, we will be addressing these very, very pertinent issues on how and why the impact of physical illnesses have an associated reduced life expectancies along with emotional and mental states. Swami Vivekananda said, "The cheerful mind perseveres, and the strongest mind hews its way through 1,000 difficulties." And clinicians across the world, psychiatrists who look after people and their minds, we are very privileged to have two of the world's best psychiatrists with us this evening. My pleasure and my great honor to welcome Dr. Gautam Saha, who is the Vice President, cum President-elect of the Indian Psychiatric Society. Welcome, Dr. Saha. He is also the Vice President of the SARC Federation of Psychiatrists and the Vice President cum President-elect of the Indian Association for Geriatric Mental Health. However, if you think he's only leading these posts as a leader in the world, I might tell you he's actually the director of the Clinic Brain and Neuropsychiatric Institute and Research Center, a very practical clinician who has sees hundreds of patients every day and has also published many articles in both national and international journals. We will be hearing from him tonight in a very short while, but I will now move on to welcome our very dear Dr. Afzal Javed, who has joined us from UK. Good evening, sir. And Dr. Javed is the president of the World Psychiatric Association. He is a consultant psychiatrist and an honorary professor at the Institute of Applied Health at the University of Birmingham and a professor at the Warwick Medical School in UK. He has also served as the Royal College of Psychiatrists UK as a deputy and associate registrar and has been the chairman of the West Midlands division of the college. He has published more than 140 scientific papers and has authored 6 books and monographs on different types of psychiatry. So here this evening, we have two of the great stalwarts of psychiatry, and the president of the World Psychiatric Association will be addressing this particular issue of comorbid issues in mental health and has actually included them in his action plan for the next 3 years as one of the top 6 priorities in the field of psychiatry. So I will now invite Dr. Saha to address this webinar. His topic for today is psychological consequences of physical illness. Dr. Saha, over to you, sir.
Just I'm taking time to sharing this my screen. Good evening, ladies and gentlemen. Today, it is my great privilege to speak in front of this so knowledgeable dais, and I'm really grateful to the American Yoga Association. And thank you, Rajashree, for your kind introduction. My topic is psychological consequences of the physical illnesses. Actually, I don't want to talk regarding the data, how much it is associated with physical illness, how much psychological consequences, psychological problems are associated with physical illness, or the physical illness is associated with the psychological illness. I am want to talk some from the basic level, from the history level. All of us we know that Johann Heinert is the term coined the term psychosomatic. And then later on, the review of the consultation psychiatry and the psychosomatic medicine by Lipovsky et al. Founded that psychiatric presentation of medical condition. There are six conditions. There are 6 points they have described among into the psychosomatic illnesses. Right. Number one is psychiatric presentation of medical condition, psychiatric complication of the medical condition or treatment. And the psychological reaction to the medical condition or treatment. Number four is medical presentation of psychiatric condition, medical complication of the psychiatric condition or the treatment, and the last, comorbid medical and psychiatric condition. But today, my lecture, I want to restrict it to only 2 points. That is psychiatric complications of the medical condition and treatment, and psychological reaction to the medical condition and treatment. Is there any illness with nil psychological response? What do you people think? Absolutely no. So the reaction of the psychological reaction may be appropriate or inappropriate. And all these appropriate and inappropriate reactions ultimately develop the affective and behavioral symptoms. So now come to the point. This is the flow chart. How the some individual can affected be by the psychological illness after getting some physical illness. There are lots of factors like stresses of illness, the individual factors which count. Now we are talking about the physician medicine, physician psychiatry, the temperament of the client or that human, that individual. What are the psychological defenses he is using after getting infected or getting any psychophysical illness? What is the meaning of illness to that individual? What are the coping strategies he is applying? And definitely his past life history or the life experiences, which ultimately lead to the psychological response and which ultimately cause the affective responses and the behavior responses and the psychiatric consultation. They need the psychiatric consultation. So I will come one by one at point. First is stresses of illness. So what are the stresses of illness? There are three tasks. Number one is acknowledgement to themselves and others that they are ill. There are lots of time with denying that we are ill. In fact, in the psychiatry, it is very important. Whenever we are saying that you are suffering from depression, very few of our clients agree that they have some mental illness. Number two, regressive dependency on the others for care. And number three, resumption of normal functioning after recovery. All these are the very important. And if you see what are the point to be noted for leading this type of stressor, like separation from family in the hospital produces, like in COVID-19, you know that whenever they isolated, whenever they disconnected, they list severe stress. And medical illness actually results in the narcissistic injury. It hurts your ego that I am suffering from this illness. Sometimes my clients in my clinic say, Doctor, how can you are ill? Are doctor is also an human being. My ego is not so strong that I am not affected by any illness. Number three, lack of privacy. When you are suffering from any physical illness, bodily exposure or invasion is somehow maybe common, and that is also may cause some stress. And in some illnesses like malignancy and thing, uncontrolled pain or insomnia is definitely one of the major reasons for stress. So illness leads to basically the disability. Number 2 point is character style of that individual. Number one is attachment style is very important. If you view of self or other formed or in the early life experiences with the caregiver. So it depends how the caregiver they have experiences in their early life. Like it may be secure, positive expectation and comfort. That is a positive thing. It may be preoccupied due to inconsistently responsive caregiving, consciously or unconsciously exaggerated illness behavior. It may be dismissing, consistently unresponsible caregiver, difficult to trust actually, not ready to engage in the psychotherapy because they don't trust the system, the treatment, or the people attached to the medical treatment. Sometimes it is fearful, become hostile and abusive caregiving if they have in their experience. There is alternate between the help seeking and help rejecting behaviors. Frequently miss appointments. They drop their appointments. And character style may be according to their personality type. You know that all of us, we know that the personality type, there are lots of personality like dependent personality, obsessional personality, histrionic personality, narcissistic personality, paranoid personality, narcissistic personality, maybe the schizoid personality. But three important personality I want to highlight. The dependent personality. Basically, the character is needy, demanding, they are clingy, unable to reassure self and seeks reassurance from the others. Always they want reassurance from the other people. Number two is obsessional. They are very much meticulous, orderly, likes to feel in control, very concerned with the right or wrong. And number three is narcissistic. These import three, those who are basically very much arrogant, devaluating, and vain and demanding, they are always thinking of themselves only. So these three type of personality disorder may cause much psychosomatic illness. I mean, if they are affected by any physical illness, they may cause much higher rates of psychological problems. My next point of discussion is coping strategies. What are the coping strategies we are taking? And what is coping? You know, the thoughts and behavior that the person uses to manage or alter the problem that is causing distress, problem focused coping, and regulate the emotional response to the problem, which is emotion focused coping. Now I'm coming to the point. There are 8 categories of the coping styles, like confronting coping, distancing, self-controlling, seeking and social support, accepting the responsibility, using escape, avoidance, planful problem solving, and conducting positive reappraisal. So your coping style itself, coping strategies may be the positive or negative. So people use some trial, some error in the selection of coping styles. Like alphabet have 6 alphabets. So if you fail in strategy A, you can take strategy B. Like this, here also, if somebody taking one coping strategies. If it is not success, then he can choose the second one. So it is not fixed for any individual. And two things is very important. One is I already mentioned problem focused coping, that is medical situation within their control, and emotional focused coping, medical situation outside their complaint. Somebody has got malignancy, severe type of like lung cancer, and which is actually doctor also saying nothing to do. In that case, they are using the emotion focused coping. Next is, what are the psychological defenses we are using? You can categorize in four categories in our defense mechanism: mature, immature, neurotic, or psychotic. Denial is the most important in this respect because the conscious or unconscious repudiation of the part of all of the total available meanings of an event to allay fear, anxiety, or other unpleasant effect. Because then whenever somebody is diagnosed as a CA lung or cancer of anything, initially what happened, most of the us are telling maybe I can't have this illness. Maybe the investigations reports is wrong. Maybe doctor diagnosis is wrong. So there is a stage of denial. This may be the adaptive or maladaptive. Adaptive means they prevent the emotional or overwhelming response from the illness, like breast cancer. And maladaptive is preventing or delaying treatment. If you don't adjust, don't accept your illness, if you don't take the treatment, then definitely the prognosis will be worse. Now I'm coming to a case, Viginet. I want to discuss it after telling a story regarding one case that a psychiatric consultation was requested for a 24 years old man. He's a quadriplegic after a gunshot wound to the spine. The physician was insistent and patient denial be broken through because the patient was convinced that he would walk again. The patient had a thorough understanding of his condition and maintained that hard work and faith restore his physical abilities. The physician worried that the patient might commit suicide when he realized that there was no chance of recovery of the function. Instead of forcing the patient to face the prognosis, the consultant recommended that the physician offer the patient training in the skill necessary to maintain himself in his current state, because the recovery, in whatever form it took, would take a considerable amount of time. Actually, he is buying time. And the patient continued to cooperate and the physical therapy and learned how to use a wheelchair or discuss the plan of his living arrangements. The physician felt comfortable with the approach because it was realistic. This is one example. Sorry. Oh my God. So, which type of denial it is? So, ultimately, what happened? Now I am coming to affective responses like anger, fear, grief, shame after getting the illness. So, what we should do, the empathetic listening will elicit predominant emotion. An illness that can evoke multiple emotional responses simultaneously or sequentially. For example, I'm telling you, the police come to see a 25 years old man just diagnosed with the testicular cancer who is angry and refusing treatment. The young man's internist cannot understand why the patient would refuse therapy needed to treat his testicular cancer. So you should give empathetically listen what he want to tell, and then only you can make him understand what are the complications after the surgery, how can he lead his life. These are all the important things. And one can also hypothesize that he feels frightened because of fear of castration. This patient is not only angry about his cancer diagnosis, but is also angry with the physician as a bearer of a bad news. So, presentation of any diagnosis to their patient is an art. Understanding the patient's anger aids psychiatrists in giving this man permission to express his feelings while tactfully helping him to see that he can do without foregoing his own treatment. The patient's refusal of the treatment also may be determined by the fear of what the treatment will involve. Psychiatrist might also work with the oncologist and his response to the patient's anger. Education by the physicians about the treatment option and the high likelihood of cure could dramatically shift the patient's emotional and behavioral response and evoke relief and hope. Next is behavioral response. Again, it is maybe the adaptive or maladaptive. Adaptive behavioral always the support seeking, altruism. Even when he knows that his days are numbered, he can involve himself in a social activities. Epiphany regarding the life priorities. He can make what are these top priorities. He want to fulfill all these things. But if it is maladaptive, non-adherence is very common in the 50% of the province. So signing against medical advice is one of the important. Sometimes we feel. So degree of patient's non-adherence and its contents you have to judge. Is the patient occasionally or consistently non-adherent? Is there any past history? Is it specific to a certain medications or type of recommendations? Or is anything else? Or is it more generalized across the different treatment or different physicians? So maintaining non-judgmental stress, use normalizing the statement, rule out the cognitive deficit, diagnose and treat any comorbid psychiatric disorder if they present. Important to assess the factors like cost, side effect, and the treatment complexity. Identify, acknowledge, and content with any cultural reasons for non-adherence. Avoid shaming, scolding, frightening to the patients. Always be cooperative, be friend, sometimes be teacher. Sometimes according to your client, you behave like this, but be friendship is very important. You have to very user friendly. I mean, you have to be very handle this situation very, very softly. Use the positive reinforcements as a motivator when possible and involve family members in the facilitating adherence. It is very important because always you should talk to the family members, near or dear ones, maybe the responsible relatives if they are present. And regarding the signing out against the medical advice, 30-day readmission rate and overall mortality of the patients is higher than in AMA. We know. So reason for signing out against medical advice, what are they? You should know before we are make them understand. Because of the anger with the caregivers, overwhelming fear or anxiety, substance craving or withdrawal, delirium or dementia maybe patient have. And if the patient is suffering from psychotic disorder or having paranoia, or he has a desire to leave the hospital to attend the outside responsibilities. So when the patient sign out, encourage them to return for the treatment. If they change their mind, don't be angry. be cooperative with their decision, and make them understand if there are any problem. If you are facing the same symptoms, you are facing, don't worry, come back to us. So how does the psychological responses to illness guide us in time efficiently manner and making useful suggestions? Whenever you feel any psychological symptom or identify, it is our responsibility to take care of them. And ultimately, definitely, if we take care of the psychological symptoms, the physical illness also prognosis will be much, much better than if you don't take care. Thank you. Thank you so much.
Thank you, Dr. Saha, for an absolutely wonderful presentation. And I'm convinced that, our audience today had a feel about, how the psychological factors actually influence our ability to cope with physical illnesses, how the complex interplay, as you explained, sir, of different personality traits, different defense mechanisms, different coping strategies, different behavioral responses, compliance with treatment, psychosomatic conditions, and in the end, how retraining and reskilling just in our ability to accept a major physical illness can go take us a very long way in adjusting to these comorbid conditions, whether they range from cardiovascular problems to nervous system issues to endocrinological problems to gynecological problems. And we know every body system, whether it's an acute illness or a long-term illness, can actually affect the psychological mind. And of course, as clinicians, we need to be mindful, as Dr. Shah has explained, of the costs, the side effects of the treatments, and work as a team really with other colleagues to get the best output for our patients. Of course, we will not take any questions at the moment. We will come back to questions in the end of in the second half for the panel discussion. And now, may I invite the President of the World Psychiatric Association, Dr. Afzal Javed, to outline the WPA action plan on comorbid illness. Over to you, sir. Thank you.
Well, Dr. Rajashree, dear participants, and the organizers of this very important, relevant, and pertinent educational activity. I'm really pleased that Dr. Rajashree and her organization has taken this very important initiative to highlight the importance of comorbidity, especially within mental health perspective. I'm grateful to Dr. Gautam Saha for setting up the scene and hope that we will be able to go with further details, but I will be mainly focusing on what World Psychiatric Association currently plans to take up effective measures in this particular area. Can I have the first slide, please? Well, thank you very much. Can I take the control for sharing it? How can I? Yeah. Dr. Rajashree, how can I? Yes, thank you. How can I go ahead?
Sir, you are able to take control of it, sir.
Thank you very much.
Thank you, sir.
But I can't move.
Anjali ji, would you mind stepping
Anjali,
in, madam?
can you help us?
Yes, I'll just
I'm
drop a
afraid that
line.
we are not very IT illiterate.
So please try now.
No, it's not. It's still not working. I can only see the first slide, but I can't. I just go. Yes. Does it take some time to go for the next slide? Yes. So let's hope that if it works. So what I will try to cover during this next 20-25 minutes to speak about the mental health, because I always feel that it is appropriate to stress why mental health is important. And then what Dr. Gautam Saha has just set the scene, the links between mental health and physical well-being, and then just talking about comorbidities and some of the work that we are doing in terms of highlighting the importance of comorbidity and the related uh, areas. I think I'm still stuck with the I can't move, so I mean, yes. So mental disorders in generally have about 20 to 25% of global disease burden. And this is very important message that needs to be re-emphasized and shared again and again so that the clinicians, the policymakers, and the service provision people are fully aware about the importance of mental health. But mental health is not only important from its own, mental health is also linked with high rates of health and risk behavior. And then coming to the physical comorbidity and the physical illnesses, unfortunately, the reports confirm that mentally ill have got more vulnerability to develop physical disorders, and that affects and leads to reduced expectancy. Next, please. So comorbidity is really a growing challenge. And I always say that this is one of the gifts of the 21st century. But looking at the practical aspects, while equitable access to comprehensive health services remain out of reach for the majority of people with severe mental disorders, this also affects their accessibility and affordability to even go for the physical health. World Health Organization and United Nations have set up sustainable development goals. And by this, they say that by 2030, we will try to reduce the premature mortality from non-communicable diseases at least by 1/3 through prevention and treatment and promotion of mental health and well-being. Now, non-communicable diseases also includes mental disorders, and people with severe mental disorders needs to be offered at least the same level of treatment for physical health conditions as the risk factors are more as compared to the general population. Next, please. So comorbidity is becoming a growing challenge for the mental health professionals. Now, comorbidity in mental health is not only gaining significant importance in our day-to-day practice, but there are two key populations with comorbidities, and each of these populations require a distinct approach. The first group are those who have comorbidities mostly due to increased life expectancy and therefore a longer exposure to risk factors. And the second set of population, those who have comorbidities mostly from more intense exposure to risk factors. For example, health risk behaviors, smoking, alcohol, physical inactivity, and obesity. So, this is how mentally ill are affected from two sides in terms of the comorbidities. Next, please. And when we look at the global burden of diseases due to the mental disorders, it continues to rise, especially in low and middle income countries. And we do see that people with mental disorders have a 2 to 3 times higher average mortality compared to the general population, which unfortunately translates to a 10 to 20 years reduction in the life expectancy. And then people with mental disorders are more likely to engage in lifestyle behaviors that can constitute further risks. Next, please. So, looking at the current literature, and as Professor Gautam Saha was also mentioning, for example, cardiovascular diseases confers a tenfold higher risk of death than suicide in people with mental disorders. Severely mental disordered patients also have high rates of diabetes. They are more prone to infectious diseases like tuberculosis, hepatitis, HIV/AIDS. And now, when we are passing through this challenge of COVID pandemic, we also feel that the mentally ill are unfortunately more predisposed and vulnerable. Next, please. So, what does this really bring in terms of our joint efforts and our future strategy? The World Psychiatric Association, as Rajashree has mentioned, this is an umbrella organization of psychiatrists and representing more than 250,000 psychiatrists worldwide. And we believe that any additional risk factor that can have an influence on mental health that needs to be highlighted by this professional organization. And comorbidity is one of the most important issues that is facing health systems in the world today. And therefore, WPA is committed to work to improve the management of physical health conditions and to support the reduction of individuals' health behavior constituting further risk factors for these illnesses. Next, please. World Psychiatric Association plans an action plan every 3 years. In this October 2020, WPA General Assembly passed an action plan which WPA will be undertaking during the next 3 years. And if you look at the slide, you will find that dealing with comorbidity in mental health is one of the salient features of our 2020-23 action plan. And this again signifies how WPA is putting a lot of emphasis on dealing and discussing the issues of comorbidity from a mental health perspective. Next, please. So, for each action plan, WPA has identified and formulated a plan specifically by establishing different work groups on these action plans. I'm really pleased to announce that WPA has also recommended and established a working group on comorbidity with Professor Norman Sartorius as the chair of the action plan group. Now, this group has already started working we already met a few weeks ago, and these were the main objectives of this group, which will be translated into WPA's future work. So, number one, to identify topics related to the comorbidity. Number two, identify the individuals. And number three, to have liaison with other groups, especially child, adolescent, and public health, so that we can really have some joint collaborative work. Next, please. So just taking this opportunity to thank the organizers for raising this particular issue of comorbidity and mental health. I just want to emphasize that World Psychiatric Association is equally responsive and sensitive to this area. Next, please. Next slide, please. We believe that this is a bi-directional challenge. Bi-directional in the sense that physical and mental health comorbidities are part and parcel of our day-to-day clinical practice. And this bi-directional relationship can be elaborated with the facts that different exposures to risk factors driving the development of both physical and mental disorders can actually increase further risks. And people, especially with severe mental disorders, including moderate to severe depression, bipolar, schizophrenia, drug abuse, and many other related disorders, have a 2 to 3 times higher average mortality compared to the general population. And we believe that equitable, affordable, and accessible comprehensive health services are the answer to deal with these bi-directional challenges between mental disorders and other physical disorders. Next, please. So, what is the most important aspect that we can really offer, or we can at least acknowledge and start sharing with others? And that is the practice of mental health needs a public mental health approach. And this becomes even more pertinent when we are talking about this bi-directional relationship with mental and physical disorders. Whereas we believe and we have seen the results that the preventive aspects of dealing with many disorders, for example, obesity, diabetes, cardiovascular, cancer, oncology, respiratory medicine, there is a chance that we can play an important role in minimizing the effect. So, based on that, I think we should also now practice mental health as a public mental health approach. And for that, the doctors, the physicians, the medical professionals have got an important responsibility to pass on the message to our patients. Next, please. Next slide, please. So, with these words, I really want to sum up and emphasize and really appreciate what the organizers have done in terms of making this important subject live. And I do feel that with our joint efforts and with our future strategies, we will be able to emphasize not only among our patients, but also medical patients who may be exposed to further psychological stress. Dr. Gautam Saha has very beautifully explained that the psychological effects of any chronic or acute or long term illness, whether this is physical or whether this is non physical, those are very apparent. I think this is one future area where mental health and physical health needs to be jointly facing this particular challenge. And I just want to repeat it again. The best effort which we can do is through the public mental health approach, so that prevention and promotion about the concepts, about the ideas, and about the ways how can we cut down the chances of these risks, that will actually be very helpful and beneficial for our patients, for our families, and for the carers. So, Dr. Rajashree, thank you very much for giving me this opportunity, and I hope that your organization's such efforts will go a long way in making this particular topic more relevant and appropriate. And while Dr. Gautam Saha is also here, I want to take this opportunity that through his efforts, Indian Psychiatric Society, which is a very important and one of the biggest member societies of WPA, we would really like to see some of the action work in terms of looking at these bidirectional challenges through his and his team's leadership in India. And that will certainly help us in propagating and bringing Indian experience as a model, a role model for other low income countries, where unfortunately, unlike the West, we are still having difficulties in managing the medical and the non medical health problems. So, thank you very much. And I will be more than happy to answer any queries or any further action points.
Thank you very much, sir. You have beautifully detailed why health is a state of complete harmony of the body, mind, and spirit. And of course, before we move to the questions, your talk reminds me of a beautiful quote by William London, who said, "To ensure good health, eat lightly, breathe deeply, live moderately, cultivate cheerfulness, and maintain an interest in life." So, as clinicians worldwide, and you, sir, you're leading a group of 250,000 psychiatrists in the world, and this is an immensely important area. And of course, we have a lot of viewers tonight, watching on the YouTube page, the Facebook page, and also sending us questions through their WhatsApp. So I will take the questions first, if you do not mind, and then maybe there is certain other two things we might want to discuss if we have time. We have a question. Does the WPA help tertiary hospitals to manage comorbidity in mental health in case of patients suffering with terminal diseases? This is a question for Dr. Javed. So, sir,
Yeah.
would you want to answer this, please? Thank you.
I think the speciality of liaison psychiatry, and especially looking at having the liaison with those medical specialities that are dealing with chronic and life threatening illnesses, is really growing as one of the challenges and one of the new specialities in many parts of the world. And I know that in many developed countries, the general hospitals are very keen to develop the departments of liaison psychiatry. Of course, when it comes to the low and middle income countries, I mean, not only talking about tertiary care, even in primary or secondary care, we do not have enough resources to offer or to really establish these facilities. What to talk about countries where there is only one psychiatrist for even more than 1 million population. So I think what we need to do is that, and this is what WPA firmly believes, the capacity building in terms of preparing our physician colleagues, non-mental health colleagues, our nurses, our social workers, our allied mental health professionals to really take this responsibility to develop some support and some guidelines which can be incorporated in these tertiary services. Of course, it will take a long time, but that is the only way. I mean, one of the other best example is that if you look at what happens in a medical school after the graduation, hardly under 5% of medical graduates choose psychiatry. But if the 95% of the medical graduates have not been exposed to understand and acknowledge the importance of psychiatry, they will never ever be sensitive to the needs of the psychological well-being. I'm not saying that we convert all 100% to become psychiatrists, but what I'm saying is that at the level of undergraduate, if we promote and if we tell them about these aspects of psychiatry, when they will become physicians, oncologists, surgeons, GPs, then they will always remember that this is something which needs to be accounted for.
So yes, of course, we wish we could convert everyone or inspire everyone to become a psychiatrist from medical school, but the aim should be as many as possible. And with yourself at the leadership, and it's in these unprecedented times, we can see a lot of hope and future in addressing these comorbid conditions with yourself and Dr. Saha from the Indian Psychiatric Society's point of view. And I also have another question, Dr. Saha. If you would like to respond to this question, sir, is there any helpline in the times of COVID for managing mental problems of old people? And because this question has come from the Indian context, I am requesting Dr. Saha to respond to this question, sir. Any
I know.
helpline for
Rajashree will
managing
be
mental health
better. Rajashree can answer this better way, because in the first, we have started the management of the health issues in the COVID in the telephonic
Teleminding.
consultation.
Teleminding,
Well,
yeah.
and it was done by the West Bengal State branch of Indian Psychiatric Society initially. And there are lots of other branches after that from the Indian Psychiatric Society itself. Almost all of the states done this from their own states in their own languages also. So it was great job. The people take their tasks and have done their best, and we have continued it till now. Till now, we are continuing that. I hope that helps our people a lot. Even we people are. Rajashree also doing. Dr. Rajashree has also took part of it. Me also, and in fact, Dr. Rajashree was the initiator. So one of the initiators. So it will be really great, and there are lots of helpline even from Indian Psychiatric Society in every state in their regional languages also.
Yes, thank you, Dr. Saha. And of course, to our viewers, if you need any further details, we will be more than happy to answer the questions. So please email or WhatsApp us with your questions. We will take it from there. And whilst we await any further questions, while we still have a few minutes, I would like to ask this question to both my esteemed seniors. They've both been my teachers, so I've learned a lot from them in my career in psychiatry. Something we need to, and of course, this is patient point of view, but comorbidity needs a lot of interactions with your other professional colleagues from other disciplines in medicine, surgery, gynecology, and the rest of it. How do we, as clinicians, try to foster this link of a team working? We cannot work individually when we are managing it. How do we improve communication? Say, we are not talking about a big organization like NHS, where you automatically have a system of communicating. But maybe when you're working in your own little clinics, maybe in Bengal or in Delhi, wherever you are, practice based, how are we going to establish these communications, sir? So that the patient care is very streamlined, lean ways of working, and it's effective for the patients. Any advice on this, sir?
Well, if Dr. Saha allow me to answer this question, I think WPA is bringing a very interesting model in this way for this particular issue. what we are doing is that at our regional, thematic, and world congresses, we are inviting the other related health professionals to come and do some sessions for the attention of our membership at that level. And I think what I would suggest and what I would recommend to our member societies that they should also have special meetings, special sessions, inviting these different non-psychiatric health professionals and to start interacting with them in terms of joint policies and joint working. And similarly, for example, Indian Psychiatric Society, I'm just taking the example of this society. In
Yes.
India, there are so many other professional organizations of the gynae and ops, cardiology, respiratory medicine. It will be appropriate if Indian Psychiatric Society approaches them that, hang on, you are having your congress on cardiology. Would you like us to present a session over there? So that will actually encourage the confidence and the links between us. And this small link will then be will lead to further developments. The other thing which I always emphasize while working in NHS and the university here in Birmingham and Warwick, every specialty has got their own postgraduate programs. How often psychiatrists have offered to the other program directors that can they put one or two lectures on mental well-being and mental health in the postgraduate program of cardiology, in the postgraduate program of rheumatology or internal medicine. So that could also be a step forward in terms of building relationship and building confidence between different professionals.
Thank you very much, sir. And I think we will surely take this forward. And also the last conference, the annual conference in Kolkata, when we had, there was a whole session dedicated to interdisciplinary working with other colleagues. But I think that's just a start. We need to take this much more forward. And as we near the end of this program, I think with a couple of minutes left, I will take one question that has come from the audience. And that was also something I wanted to ask Dr. Shaha, who is already stressed, sort of explained on work-related stress and how, different methods, can help. There's a question for stress management for people working from home, especially under these times of COVID, where it's reversed now. You're working at home, managing home, but you're still stressed. You can't get out of it. So, some advice for our audience, please, tonight.
It needs actually a whole lecture because stress management is really very important factor for all of us. And regarding the COVID-19, this lockdown and social distancing, which is actually not physical, it is only limited to physical distancing, not mental distancing. All these things are very important. Keeping in this mind, there is some mental health issues are there. In fact, in the Indian Psychiatric Society has done a study on it, and we have found that 9.8% people have depression in this phase. 38.5% patients have anxiety disorder, and more than three-fourths of the people have a moderate level of stress. And the people who are working from home is definitely because of the reasons is very simple, because they are restricted to at their home. They are not able to go to their office. They are not able to mix their friends. They are missing their friends. They are missing their near and dear ones. So it causes the immense stress. And to come out of this is definitely you should follow some routine life. You are doing work from home, that does not mean you wake up late. You should wake up at this fixed time, do some physical exercises, mindfulness, maybe the yoga you do, and after you're finishing your work, spend the quality time with your spouse, which is not getting usually this time, or you may give some time with the kids, quality time, play with them, and also give your parents if it's there at our home, give them. So it will definitely keep your mind to be cool and connect with your friends over telephone. Social distancing does not mean not connecting with any people. It is a physical distancing basically. So talk to them and be happy, whatever problem. But still, after all this doing, you are feeling depressed, anxious, then you have to consult with the mental health professionals. This is my suggestion.
Thank you very much, sir. And we have sort of come to the end of this session. What a fantastic and informative session we had. I have learned a lot from both of you today, and I'm sure our viewers have had a great experience. And there are lots of questions. This is only a start to talk about it. The whole idea was to start making us think, to start having the conversations forward, and to actually think that, as Gautam Buddha said, to keep the body in good health is our duty. Otherwise, we shall not be able to keep the mind strong and clear. So to keep the body, we have to keep the mind. But each negative belief will weaken this partnership between the mind and the body. On that note, good evening, take care, and namaskar to all of you. Thank you for being with us at this webinar of the American Academy of Yoga and Meditation. Good night.